Hi, my name is Linda Okafor, and in this Week 9 journal, I encountered a deeply concerning case of a 10-year-old boy presenting with severe depression and suicidal ideation. His plan involved asphyxiation and he was quite detailed. This case was emotionally charged and unlike anything I had experienced before. The patient described persistent feelings of sadness, worthlessness, and an inability to envision a future without pain. His parents reported social withdrawal, loss of interest in activities, and a sharp decline in academic performance. This interaction profoundly expanded my understanding of the psychiatric mental health nurse practitioner role, especially regarding pediatric mental health and crisis intervention. Assessing and managing suicidality in a child requires a delicate balance of empathy, thoroughness, and swift action to ensure safety. It also highlighted the importance of collaborating with families, schools, and community resources to address multifaceted needs. As a mental health nurse practitioner, I recognized my role as not just the provider for the child, but also a guide and educator for the family, helping them navigate their own emotions while supporting the child through treatment. The case reinforced the need for vigilance in identifying warning signs of suicidality in young children, which can sometimes be overlooked due to the assumption that children are too young to experience such profound despair. One of my strengths in this situation was my ability to establish rapport with the child, despite his guided demeanor. By engaging him in a calm, non-judgmental, and age-appropriate manner, I created a safe space for him to share his thoughts. I used active listening, reflective responses, and gentle questions to explore his feelings and plan in detail. However, I identified a limitation in my initial difficulty processing the severity of his suicidality. While I maintained composure, I felt an internal surge of emotion that briefly made me second guess my words. As I acutely as I was acutely aware of the gravity of the situation. This highlighted my need for ongoing emotional resilience training to remain fully present and effective in such high-stake interactions. Reflecting on this interaction, I realized how critical it is to use my presence and demeanor as a therapeutic tool. I maintained steady eye contact, used a soothing tone, and leaned forward slightly to convey attentiveness and compassion. I avoided overwhelming the child with direct questions initially, instead allowing him to set the pace of the conversation. My calm and reassuring approach seemed to ease his anxiety and encouraged openness. This experience taught me that even very young children can articulate complex emotional pain and form specific plans to end their lives. It underscored the importance of asking direct but sensitive questions about suicidal thoughts and plans, regardless of the patient's age. Additionally, I learned that involving parents in a constructive way, educating them on warning signs, coping strategies, and the value of family therapy can be pivotal in creating a supportive environment for the child. Moving forward, I plan to enhance my skills in working with children by studying evidence-based approaches like trauma-focused cognitive behavioral therapy and play therapy. I also intend to practice self-care and debriefing techniques to manage the emotional toll of such case effectively. Finally, I will advocate for increased awareness of pediatric mental health issues among caregivers and educators to ensure early intervention. Thank you.